Okay, the next group of meds that I'd like to talk about is your angiotensin II receptor blockers, and our prototype for that is losartan, and you might know that as Cozar. You've learned about this in the use and prescribed for hypertension, but we also see this used in place of your ACEs in case a patient has a reaction to an ACE, or they develop that cough that I talked about earlier when I talked about ACEs. So you might see the patient put on angiotensin II receptor blockers such as losartan. They work essentially in the same way. They block angiotensin receptors, resulting in a decrease in blood pressure, blocking angiotensin II receptors that prevents that cardiac remodeling and deterioration of renal function in patients with diabetes. It is metabolized by the liver, secreted by the kidneys and feces. They work essentially the same way in regards to the renin-angiotensin-aldosterone system. Your ARBs are a little bit more expensive than your ACEs, so that's why your healthcare providers usually start off ordering an ACE and see how the patient does tolerate that as well. We might see it used for patients in preventative of CVAs with left ventricular hypertrophy, prevention of type 2 diabetic neuropathies, causes vasodilatation and reduces blood volume in heart chambers due to the release of aldosterone by angiotensin II. Some of the adverse effects or side effects are headache, nasal congestion, dizziness, fatigue, insomnia, angioedema, and acute renal failure. Do not use if a woman thinks she's pregnant, and of course, again, use cautiously in patients with renal or hepatic issues or patients that are already hypovolemic. Use cautiously with NSAIDs due to worse renal disease, and again, knowing which herbal supplements your patients may be taking, so do not take with Hawthorne due to possible addictive interaction. Monitor closely with patients taking potassium supplements and diuretics. And so, again, use cautiously with lithium, may cause toxicity. And that is losartan. All right. Our next medication is what you see up on the screen, called furosemide. Furosemide may be used as a medication for hypertension, but again, for a patient who has heart failure due to increased vascular volume, and therapeutically it's an antihypertensive, and pharmacologically it's labeled as a loop diuretic. And it's important that you use that adjective loop when we're talking about diuretics, because this is where the action of the medication takes place in the loop of Henle in the microstructures of the kidney. It's used for treatment of acute edema associated with liver, renal, or heart failure, as it helps to remove large amounts of fluids in short periods of time. It can be given orally or IV, and it's able to increase urinary output even when blood flow to the kidneys is diminished. This is a very potent diuretic, and because of the effects of reducing vascular volume, again, it affects such things as preload and afterload, causing a reduction in both. Because of the potency of this drug, it has a tendency to not only decrease vascular volume and increase urinary output, but it also has a tendency to excrete potassium, which may cause electrolyte imbalances along with excretion of sodium as well. Because of its effect on vascular volume, it does have a indirect an indirect result with blood pressure causing hypotension. When it's administered too fast through the IV route, a patient may experience ototoxicity, hyperglycemia, uricemia, can cause interactions with other diuretics and NSAIDs, with other ototoxic medication. Usually when the patients are put on this, especially if they're on a maintenance dose orally, as long as they have good renal function, you will see that the patients may be put on potassium supplements. So it's important that these patients come in periodically to have their electrolytes assessed. And two big effects of loop diuretics, such as furosemide, is, especially if a patient does have a good diuresis, is the fact that they may develop hypotension or hypovolemia as well, or dehydration. So you really have to monitor and put the patients on strict intake and output. And obviously it's contraindicated for patients who have severe electrolyte imbalances or increased oliguria, in which they have really a decreased amount of urinary output. And we really say that oliguria is pretty much defined as less than 500 milliliters in a 24-hour period. You really have to watch patients when they're on loop diuretics, especially when they're in fluid overload. Usually when they come in with an exacerbation of their heart failure, usually their weight is up, they might have crackles in their lungs, and this is why they're given IV furosemide, because it works very quickly, and it very quickly will help reduce a lot of that vascular volume and help reduce the workload of the heart. And then usually patients are put on maintenance doses, usually orally, maybe once or twice a day. It's really recommended that when we do teaching with these patients that they take their diuretics before 5 o'clock each day, so they're not up through the middle of the night going to the bathroom, risking safety, and of course interrupting their sleep. They should come in periodically to have their electrolytes checked, monitor their blood pressure. Patients should be weighing themselves on a daily basis, and when they gain either 2 or 3 pounds overnight, it's important that they call the doctor, especially if they start having shortness of breath or notice that they're developing edema anywhere. So again, assessing blood pressure, heart rate, and respirations. Patients should be weighed dailies, and they should be doing this on their own when they go home. Strict INO, and assessing their BUN, creatinine, and potassium levels, and making sure that they're taking the drug correctly, and really teach them about signs and symptoms of hypokalemia, where they might start having leg cramps and other early signs of low potassium levels as well. Other than that, we see, as I mentioned before, electrolyte imbalances, orthostatic hypotension, syncope, and tachycardia, and dysrhythmias. All right. The next drug that I want to talk about is atenolol. All right. So let's look. And atenolol is a beta blocker. And how do beta blockers work? What they do is they help decrease the contractility of the heart muscle, and this is how they help with decreasing blood pressure. It's an anti-aginal therapeutically, and pharmacologically it's classified as a beta adrenergic blocker. And we see the suffix with these drugs end in OL. Used in the treatment of chronic heart failure, hypertension, stable angina, and post-acute MI. blocks beta adrenergic receptors in the heart. Angina, because it actually slows the heart rate and reduces contractility, which lowers the myocardial O2 demand. And it also has some vasodilatory effect as well. Again, will affect blood pressure and heart rate, so really assess for side effects of bradycardia, rebound excitation, can interact with other antihypertensives and anticholinergics. It's important that when a patient is on this, they do not stop the drug abruptly. They should titrate it down and do not use if a patient becomes extremely bradycardic or they develop heart block, because they can go into cardiogenic shock. Again, assessing the renal and liver function, and anticholinergics may decrease absorption, and use cautiously with digoxin, which we're going to talk about in just a few minutes, or any other antidysrhythmics medications due to depression of the myocardial conduction, and can cause some serious arrhythmias such as heart block. If overdose, we might want to use hemodialysis with the patient and possible external pacemaker or atropine to help increase heart rate. Again, always assess blood pressure, heart rate, assess for orthostatic hypotension, dizziness, headache, flushing, or chest pain because of hypotension and decreased perfusion. Angioedema can also occur as well. And again, assessing labs as such. All right, the next drug I want to talk about is digoxin, which is therapeutically used for heart failure, and pharmacologically it's a cardiac glycoside and an inotropic agent. And what I mean by an inotropic agent is that this is a drug that will alter the force or energy of the heart's muscular contraction. And what it is a positive inotropic drug, meaning it increases the force of contraction, better perfusing the patient as well. And it has a negative chronotropic effect, and a chronotropic drug is one that changes the heart rate. And what we mean by negatively affected, it will lower the heart rate of a patient by the administration of digoxin. So it has a positive inotropic effect and a negative chronotropic effect. It increases the strength of myocardial contraction, being a positive inotropic action, but decreases heart rate, making it a negative chronotropic drug. It increases cardiac output, which alleviates heart failure symptoms, and increases exercise tolerance as well. It also increases urinary output, which decreases blood volume, resulting in decreasing pulmonary congestion and peripheral edema. It also used in patients not responding to ACE inhibitors or heart failure patients with AFib, and it will affect the speed of myocardial conduction. It decreases sympathetic nervous system activity and increases parasympathetic activity, and helps attenuate the excessive sympathus activation that causes tachycardia and worsens heart failure. It will suppress the SA node and slow electrical conduction through the atrioventricular node, resulting in a decreased heart rate, allowing a greater diastolic filling of the ventricles, providing a better coronary filling, and a better perfusion of the heart muscle itself. Digoxin's been around for a long time, and we can give this drug either PO or IV route, and it's been around for centuries. And what's important to know, if you have a patient that has been on digoxin, it's important that we get what we call a digoxin level, because we want to make sure that is in with therapeutic range, because patients, because it's excreted through the kidneys, can easily become digitoxic, especially if their potassium levels are low. So I think the therapeutic range for digoxin is anywhere between 0.5 to 1.5, and so we'd always want to be sure that we knew what that level is, especially on patients who have been on it for a while, because some of the early signs of digitoxicity are nausea and vomiting, and as the patient becomes more toxic, they start to develop some hallucinations. And one thing that if a patient says that they see halos, that may be an indicator that they're severely toxic with a drug of digoxin. It is a drug that can cause bradycardia, so as nurses, it's very important that we assess their heart rate before we administer that, and we would check their apical pulse, and if it's 60 or below, we might want to think twice about giving it because it could lower the heart rate even more. Thrombocytopenia has been known to occur along with intestinal ischemia, and it's contraindicated in patients with renal impairment, patients that have had a history of VFib, or acute MI as well. So that's digoxin. And like I said, we used to use this drug a lot more, maybe 20, 30 years ago. It really doesn't affect mortality. It's more of a backup drug, as I would say, with patients who have heart failure. It inhibits sodium, potassium, and ATP, those critical enzymes responsible for pumping sodium ions out of the myocardial cells as well, and exchange for potassium ions. As sodium ions are accumulated in myocytes, calcium ions are released from their storage areas in the cell to activate that contractile element. The release of calcium ion produces a more forceful contraction of the myocardial fibers. So that's how digoxin works, to increase that force of contraction. It's definitely contraindicated in ventricular dysrhythmias or somebody with hypoglycemia as well. And it's important to monitor pulse and really teach a patient, if they go home on digoxin, to be able to take their own pulse, so that if they start to have periods of dizziness or syncope, that they can assess their pulse rate. Maybe they might develop some type of arrhythmia, which affects the conduction of the heart muscle. And so, please, I want to tell you that digoxin doesn't really affect blood pressure as significantly as it affects heart rate, okay? It just helps to provide a better force of contraction for the heart muscle. Again, assess weight, INOs, assess renal function, knowing what the patient's BUN and creatinine and potassium levels are, and assess any type of meds that the patient's taking. As you can see here, interactions with glycoside and macrolide antibiotics may interact, and grapefruit juice and NSAIDs as well. So that's digoxin. All right. Just make sure they get a digoxin level. All right. All right, the next drug that I want to talk about is your potassium-sparing diuretic called spironolactone, or also known as aldactone. You learned this back in Nursing 123, where it's used for mild hypertension and edema, sodium retention associated with heart failure, and nephrotic syndrome as well, which is a glomerular inflammation. And we might also see it used for liver disease such as ascites. May also be used for pre-op treatment of primary hyperaldosteronism, improves survival and hospitalization of patients who have heart failure, and edema related to PMS, polycystic ovary, and also used for patients who develop hirsutism, in females, which is excessive amounts of hair in places where women should not be having hair. This is more of a mild diuretic, and sometimes you might see the patients on this in addition to a loop diuretic, because over time when patients have heart failure and they've been on say for instance furosemide for a long period of time, you may see the effects start to kind of slow down, and a lot of times they are ordered to be on a secondary diuretic, and this may be the drug because it is a potassium sparing diuretic, which means the patient doesn't excrete potassium. So you would not give potassium supplements with this medication. Anybody that has a severe electrolyte imbalance due to renal insufficiency or any other reason, you would definitely want to question whether or not this drug be given. Side effects or adverse effects could be hypotension, hyperkalemia, renal failure, leukopenia, which is a decreased number of white blood cells that help fight off infection, or either thrombocytopenia, and that is a reduction of platelets as well, which could cause the patient to have bleeding issues as well. Patients should be educated that potassium should be consumed in moderation. No need to increase their oral amount with this water pill. So again, really monitoring these patients, especially if they're on this diuretic as well as a loop diuretic. All right, the next medication we're going to talk about is nitroglycerin, Nitrobid, or isosorbide, or Imdor. This is a medication which is therapeutically used for anti-anginal, and pharmacologically it's a nitrate. And how nitrate works is they just cause vasodilatation, usually of the venal vessels, but when in higher doses you might see some arterial vasodilatation as well. When patients are first put on this, you might see them have a headache because it also vasodilates the vessels in the head, causing them to develop headache. Because of the vasodilatory effect, it might cause a drop in blood pressure, causing orthostatic hypotension, headache, tachycardia. Be careful when using it with other antihypertensive drugs. It can cause severe hypotension. Beta blockers and calcium channel blockers decrease tachycardia caused by nitro. Contraindicated for patients with head injury, glaucoma, or severe anemia. And always with these drugs that are, vasodilating the vessels, we're always assessing blood pressure and heart rate. And most of the time, when we're starting our patients on these, our patients are in the hospital. So we're able to monitor their blood pressure and their heart rate to get the dosage correct. Because when patients are stabilized and doing well on these meds and tolerating them well, that it's not dropping their blood pressure or heart rate's too low, then we can go ahead and safely send them home on these medications. But it's still important to teach our patients about looking for signs of, hypotension where they might feel dizzy. That's why we encourage them, if they possibly can, to take their blood pressures once in a while and really to learn how to take their pulses as well, just to kind of feel what their heart rates would be. So if they're still having problems, they can call the doctor and let them know what their heart rate is, because some of them affect both heart rate and blood pressure. Some just only affect blood pressure. Some just only affect heart rate. So that's the kind of teaching that we need to do with these patients. And of course, others may affect their electrolyte balances and electrolyte levels as well. So that's the kind of teaching that we need to do with these meds, because when they're doing what we want them to do, patients can do very well and live a very active life and a good quality of life. But if we don't have them on the right dosage or even on the right meds, our patients are going to have really serious problems that really affect their cardiac and respiratory status, and may also affect their quality of life and put them in a dangerous situation as well. And so that's why we have to be sure that when we send them home on these drugs, that they're going to do well on them as well. Okay? So, and it really is about teaching them what they need to know what they're capable of understanding, maybe teaching the family as well, and then having them be somewhat responsible for being able to see if they're able to tolerate these meds when they go home and start, living their normal lives. All right, so very important to understand. So hopefully when you begin to understand these medications in the way that they work for patients that have coronary artery disease or heart failure, because these are very complex disease processes that, years ago, 20, 30 years ago, when patients were diagnosed with heart failure, many of them died within 5 years after their diagnosis. But because of these drugs, particularly our beta blockers, really have helped these patients live a much more productive life, may help them live a longer life, and have improved their quality of life as well. So these meds are very important. But with any med, particularly these meds, there's always the potential for serious side effects, so that we need to know what is going to happen when these patients get them or administer them to these patients, because we don't always know how they're going to react, especially when the first time they're receiving them. Okay? All right. So we've talked about all these medications, and one of the next meds that is on the list for week 2, which we talked about in week 1, is heparin. And again, we're talking about the use of heparin with coronary artery disease. Again, we might see these patients who might have unstable angina have to be put on heparin because maybe they develop what we call a non-STEMI, and your lecture instructor in Nursing 122 will go over the difference between STEMI and non-STEMI. I talked a little bit about it in Nursing 100, but you'll get much more information about those two types of situations that may occur. But again, heparin is used to treat DVTs, PE, and patients with unstable angina, to prevent thrombosis in high-risk patients. And so it's really important that you look in your book and understand exactly what heparin does in regards to clotting. And I explained that in week 1, and I want to be sure that you do know that it doesn't dissolve the clot, but it prevents the enlargement of the clot that is actually present. And it's very important to assess their coagulation profile when we're talking about heparin, and we usually hold it if the platelets are below 100,000, and to notify the doctor. And again, we can see heparin used prophylactically and then used for these very serious situations. And as we talked about Nitrobid before, remember, we can see Nitrobid given, or nitroglycerin given, in many forms. It can be given as Nitrobid orally. It can be given as a transdermal patch. It can be given as a little tiny pill that our patients with angina may take if they have chest pain. And we may see a patient have their nitroglycerin tablets in a little dark colored bottle that protects it from the light, because when the light gets into nitroglycerin, it eventually will cause an ineffective drug. And these patients are taught how to put nitroglycerin under their tongue if they have chest pain. Take the first one, wait 5 minutes. If the pain is still there, take a second, put it under their tongue, wait 5 minutes. And if they still have no relief from that pain after the third nitroglycerin, then they're encouraged and told to go to the emergency room and be assessed for possibly unstable angina or an acute MI. So those, and we can also give nitroglycerin IV, and we might see sometimes nitroglycerin given into the intracoronaries in the cath lab as well. So those are all the various routes and the different ways in which a nitroglycerin can be administered. All right, our last medication is to talk about increased in cranial pressure. for patients that might have some kind of head injury, and that drug is called dexamethasone. It's a anti-inflammatory and immunosuppressant. Pharmacologically, it's a glucocorticoid, and it treats inflammation. This has been a steroid that's been around a long time. It works by decreasing or preventing tissues from responding to inflammation. It also modifies the body's response to certain immune stimulation. It's a steroid. It's a glucocorticoid. And some of our patients may have difficulty sleeping, feeling of a whirling motion, increased appetite, increased sweating, may have indigestion, mood changes, nervousness, weight gain. It's encouraged not to take with a live vaccine. Again, if patients are on steroids for a long period of time, they should not be stopped abruptly, because a person's own adrenals will not be able to provide the necessary steroids that the adrenals produce, because when they're given from an outside source or an exogenous source, our own adrenals tend to decrease the secretion or excretion of our steroids that come from our adrenals. So they need to be slowly withdrawn from the medication, where we would see the patient get decreasing doses as well. So again, assess vital signs, assess for adrenal insufficiency, hypotension, weight loss, weakness, nausea and vomiting, anorexia and lethargy, and assess for cerebral edema, and to also assess neurological function, looking at consciousness, increased headache, visionary issues, doing a PERLA on the patients, assessing hand grasp, speech, and all those things in which we assess people neurologically in case they've faced some kind of head trauma, hematoma, subdural hematoma, where there's swelling in the brain. This is where we might see the patient receive dexamethasone or some type of steroid IV to decrease cerebral edema as well. So this pretty much concludes all the medications that you're responsible to know. But like I said, all these cardiac meds you have had in Nursing 123, but when you discuss them, they were prescribed for patients with hypertension, but now we are seeing the same medications prescribed for patients with congestive heart failure and coronary artery disease. So once you start hearing the pathophysiology that goes with these two heart conditions, it will make sense of why these meds are ordered for these conditions as well. I'm also going to post that practice MARS sheet that I have in week 2 because it has some great thinking questions, and hopefully you've been able to kind of decipher what the answers to that are. I'm also going to post a few videos on Mrs. Bell, Professor Bell from the nursing lab has made videos in regards to the correct way in which to administer IMs, sub-Qs, and intradermal injections, because that will be your first skill checkoff when you have your lab in the summer. So I'm going to give you those videos so you can begin watching those and kind of get familiar with those skills so that you can, again, get that learning embedded in your head so that when you have your lab, hopefully in the summer, that you'll have a little introduction to those types of skills as well. So I hope this has been helpful in talking to you about these medications, and please pay attention to the lecture concerning heart failure and CAD so that these drugs all make sense to you. And if you have any questions, I'd be happy to answer them, and I look forward to seeing hopefully all of you, but as many of you that can make it, with our first WebEx chat this week. All right, so have a great evening, and thank you for your attention. And like I said, please go over the practice problems at the end of your DA book, and I hope everybody's doing well with dimensional analysis, and hopefully I'll be able to chat with you about your DA knowledge, and to see if anyone is having any issues with dimensional analysis problems. Okay, so I've enjoyed bringing this information to you, and so please, like I said, if there's any question or concern about anything that I've discussed, please bring it to my attention. And I hope you all have a great evening and a great day. Thank you.